Ready to start? So this is Dr. Leshin, we all know him very well. He's going to talk today on peripheral nerve tumors. He's an advisor with Shred, who will be here shortly.
We'll see. No disclosures. We're going to start with a case. So I talked to Dr. Shredhara about this. I sent him the rough draft, and his main commentary was sort of saying, pimp the audience, quiz the audience. That needs to be a big part of your presentation. And also, he said the second half is boring and cut it way down. So to start with, this is a case that we saw in the EMG lab, a 38-year-old male presented to the EMG lab for evaluation of pain and altered sensation in the left lower limb. And for those of you who haven't done EMG yet, it's the lower limb, not the extremities, unless it's below the knee with Shred. Symptoms started approximately 5 years ago. They were previously intermittent, but became persistent over the last 2 to 3 months. So at this point, very broad diagnosis, because we don't know if this is coming from his back, from his leg, and largely common things in the EMG lab should come first in your differential radiculopathy, diabetes, entrapment, trauma. Then there's also lesser consideration for things like plexopathy, vasculitis, immunologic, immunodeficiencies, infections, toxins, malignancies. He said it was localized to the lateral left foot, lateral 2 to 3 toes, described as burning and stabbing. Was worse at night and with sitting. It was not exacerbated by ambulation. He said he had numbness and tingling in the same distribution. The pain was not alleviated with gabapentin or oral steroids. He did report some improvement with Vicodin, but he did say this largely just put him to sleep, so he didn't notice the pain. He said no weakness or change in ambulation, no falls or trauma, no back pain. Previous evaluation, X-ray of the lumbar spine was negative. X-ray of the left foot was negative. And venous Doppler ultrasound of the left lower limb was negative. So now it's starting to sound a little bit more like a mononeuropathy. No other significant past medical history except for some wrist tendonitis. Prescriptions were just what I talked about, the gabapentin, Vicodin, recent oral steroid pack, no allergies. No family history of cancer or neurologic disease. He works in a hospital and environmental services. Lives with his wife and 2 children, smokes a half pack a day, drinks socially. Once every 2 or 3 months, he goes and ties one on. No drugs, and he's independent for ADLs and ambulation. Review systems was pretty much negative otherwise. No fevers, chills, weight loss, chest pain, shortness of breath, urinary retention. And the lack of the systemic signs and symptoms make some of these other things I talked about less likely. Infections, toxins, diabetes, immunologic and vasculitis, or other rheumatologic pathologies are seeming less likely. Physical exam, he's alert. There's no warmth, tenderness, edema, or deformity in the limbs, so it's less likely a focal infection. It's got full range of motion. There's no muscle atrophy, so when we're starting to think about what nerves could be affected, there's no muscle atrophy, and the strength, he's 5 out of 5 throughout his lower limbs. On exam, he has decreased light touch and pinprick sensation in the lateral left foot, starting at about 4 to 5 centimeters distal to the lateral malleolus to the little toe on the dorsal side, and in the lateral plantar distribution, but not over the calcaneus or 4th or 3rd toes. I think that's actually supposed to say 2nd or 3rd. Light touch pinprick was normal over the right lower limb. Slump test positive on the left, negative on the right. Reflexes were all 2s. There's no clonus. Babinski's was downgoing, and there's no Hoffman's. So this is a drawing of the distribution in his leg. He had a sensory abnormality starting, and it actually started just above his knee. So starting to think about where this is on the peripheral nerve. And also palpation of the lower posterior left thigh caused pain radiating to the foot, and there's a Tinel sign over the tibial nerve when you palpate 6 to 7 centimeters proximal to the popliteal fossa. So sort of the distal part of the back of the thigh. Also, there was a palpable nodule there, approximately 6 centimeters to the popliteal fossa at the midline, which is oblong in shape, measured approximately 2 centimeters proximal to distal and 4 centimeters medial to lateral with indiscrete borders. So now that and there's sort of an outline of where the mass was. Now that there's an identified mass, the question is, where is it? Is it in the muscle? Is it in the nerve? In the bone? Somewhere else in the lymphatic system? And what's the origin? Is this from the nerve, muscle, bone, somewhere remotely that's traveled down as a met? So what nerve is affected here? Anyone? So this is a little bit of a depiction, the medial cutaneous nerve coming out and giving branches to the plantar digital branches. So these were the sensory nerve conduction studies, which showed mild relative slowing of the left sural nerve compared to the right. The left medial plantar snap amplitude was 30% lower than the right. And the lateral plantar snap, which for those of you who haven't done EMG is the sensory nerve action potential, was 40% lower than the right. So if we go back, you can see that these two branches, these green branches, come from that sural nerve. There's more of the anatomy that the tibial nerve splits, and that sural nerve also gets a branch from before the split. Motor was completely normal, and the H reflex was significantly prolonged on the left compared to the right. So the H reflex is, in the EMG lab, is our way of simulating the reflex arc, where you stimulate a sensory nerve and it travels proximally and then comes back down as a motor. So something was preventing that sensory signal from going up, because we know our motors are normal and the H reflex was abnormal. So that means there's something in the sensory pathway. The EMG, all the muscles tested were normal. There was no fibs or sharp waves. So what's our diagnosis? So our impression was neuropathy of the left tibial nerve, proximal to the knee, affecting only sensory fibers with relative sparing of the motor fibers of the tibial nerve, possibly the result of a mass either inside the tibial nerve or outside, compressing the sensory fiber component of the nerve, so glioma versus a schwannoma versus fibroma. And that Schrid loves Sunderland's nerve mapping. So we broke out all those books, and based on the intraneural topography of the tibial nerve in the area, likely an intraneural nodule in the middle of the nerve as the only area where the predominance of sensory fibers go to the foot area. So if you're looking at the nerve in cross-section, that tibial nerve feeds a lot of different places. So the next step was getting an ultrasound. I'm sorry Connor's not here because there's a lot of ultrasound stuff, but at least Tony can appreciate all this. So this was the ultrasound, MSK ultrasound. We didn't do it. We had this done by radiology. But here you can see this shape, this sort of oblong shape, and this sort of gap in the middle surrounded by this guy. So the 2.6 by 2 by 2 centimeter soft tissue mass of neurogenic origin in the left tibial nerve, superior to the popliteal fossa, likely account for the symptomatology. Thickening of the tibial nerve fibers is seen 5 centimeters superior to the mass and 3 centimeters inferior. So the shape is sort of a long oblong, and that's what they're describing there. So then we got the MRI. You can see we'll talk more about these signs, but this fusiform shape in sagittal view and an axial, get this empty space here. So their impression, dimensions, enhancing mass arising from the left, that's a point, right? Left proximal tibial nerve just distal to the sciatic bifurcation, consistent with neural sheath tumors such as schwannoma or neurofibroma. The tumor is surrounded by edema and cystic degeneration in the nerve proximally and distally, measuring 13 centimeters. So this 2 by 2 by 2 centimeter mass had impact 13 centimeters in the thigh. So we referred to either neuro or orthopedic surgery, depending on who was going to do it. He underwent gross resection of the mass. Dr. Sridhara wanted me to contact him, but looking through the notes, he had a post-op DVT and had some complications, so I did not do that. But I did, looking back to check the record, I did have some trouble. So we've all tried to get orthopedic notes, and it's hard to read, and they don't really say much. So I looked back, because this was an orthopedic surgeon, and I found the root of the problem. This one resident that you can see here seems to be the orthopedic resident, apparently. And just for emphasis. Pathology, I actually managed to cut out the part where they said that this was a schwannoma. So a little bit more about what you're about to hear. We're going to talk about the embryology and anatomy of nerves, epidemiology of the tumors, classification, anatomic locations, clinical presentation, diagnosis and treatment for the first bit, and then we'll go into specific types of peripheral nerve tumors and imitators. As far as embryology and anatomy, these nerves are functionally and anatomically continuous extensions of the central nervous system. They embryologically arise from the neural crest tissue and axons that migrate from the neural tube. And the peripheral nerves are actually composed of numerous axons and several surrounding layers. And this is a picture of the embryology, and I think we all didn't enjoy that, so we're not going to go into that too much. But a review of the anatomy of the peripheral nerve, we have a myelinated axon, which is surrounded by a Schwann cell. And then the Schwann cells are within an endoneurium. And groups of endoneuriums are packed with collagen in a perineurium. And then multiple perineuriums, along with more connective tissue, are within an epineurium, as well as blood vessels that supply the nerve. And this is somewhat important for this as far as what tumors are within the endoneurium versus within the fascicles, and how that affects clinical and diagnostically, and also treatment as far as how effective the surgeries are. So this is sort of looking at what I was talking about. This is from Sunderland, looking at point A at the top. If you take a cross section there, it might look different. So they split and divide in the redirecting fascicles so that proximally and distally they may look different. While axons, sensory, and motor fibers travel together, at any branch point, a pure sensory, a pure motor lesion may be found. Epidemiology, these are of neurogenic origin, make up 12% of all benign tumors and 8% of all malignant soft tissue neoplasms. The age varies by type of tumor. There's generally no sexual predilection for either sex, though there's some variation based on the type of tumor. Anatomic localization. So this case reports throughout the literature exemplify that all peripheral nerves are potential locations for these tumors, and those locations determine the symptoms, diagnosis, and treatment. And this is the most chilling drawing of anatomy that you've ever seen. Just hanging out. Histology. I don't have much time. You don't really want to see past slides. I don't really want to show a bunch of past slides, but I wrote about it in the paper if you're really interested. So clinical presentation, these are often asymptomatic. Pain and neurologic symptoms are uncommon unless the lesion is large. Deeper tumors are more likely to grow large and impinge neighboring structures. And symptomatic tumors are benign 85 to 90% of the time, but malignant tumors are more likely to be symptomatic. And the numbers get a little confusing because so many of these are benign. So a giant cut of them are benign, but they're less likely to be symptomatic. But because it's such a big proportion, even symptomatic ones still are more likely to be benign. So benign tumors cause symptoms due to compression and usually not due to axon loss. If there is axon loss, it's usually minimal. And malignant tumors cause symptoms due to direct invasion of the nerve. This is sort of a key point when thinking about how these nerves act locally. So the benign ones, which is most of them, it's because of where they are rather than what they're doing. And the malignant tumors are actually acting on the nerve and causing more destruction at the nerve level. On the masses, and this was exemplified in the case we had, they're often palpable because there's largely a superficial nature of a lot of these tumors. The benign tumors grow slowly, and rapid enlargement of a mass has been shown to have a 95% positive predictive value for predicting malignant pathology. Paresthesias occur in a dermatomal distribution, and if not, it's often more likely a different etiology. They're often insidious onset in benign tumors, and the presence of neurologic deficit has a positive predictive value of 73% for malignancy. Weakness, which one author defined as strength of 3 out of 5 or less, is found, they said it's found exclusively in malignant tumors. I will say that there are reports of weakness in peripheral tumor mimics, which I'll get into more later. So pain may be presenting in benign or malignant tumors. It's often insidious in benign tumors. It's more common in malignant tumors. 75% of all patients with peripheral nerve sheath tumors do have pain, but pain is 20 to 30% predictive of malignancy. And this is, once again, where it gets a little bit confusing because so many of the tumors are benign, but at the same time, a lot of these symptoms are more predictive of malignancy. So the percentages wind up looking a little funny. And pain at rest is more indicative of a malignant tumor, whereas pain with Tinel sign is more indicative of a benign tumor. So looking up pictures of pain, I saw a lot of this, and once again, the French are going and messing things up. So pain in benign tumors, Segru proposed that pain in benign tumors is due to what he called ectopic mechanosensitivity, possibly due to increase in local concentrations of the NaV 1.8 sodium channel, leading to increased axonal transmission in response to mechanical stimulation. So what he's saying is that this is an external force pushing on the tumors, and because of that association, there's increased channels that are causing this pain sensation. Versus in malignant tumors, they proposed 2 mechanisms for the rest pain. So like we said, the rest pain is more common in malignant tumors versus benign tumors is more common with Tinel's or the patient we saw. He said when he was sitting down, so when you're sitting in the chair, the back of your thigh is pressing and that was causing his pain. So there's chemical algogens, and he lists a couple, and they continually secrete and and serve as pain stimuli, and also that there's aberrant axons that sprout and fire and cause pain. A diagnosis, as hopefully any etiology in medicine, clinical history and physical, the beginnings. We'll also talk about electrodiagnostics and radiology. So clinical evaluation, this shouldn't be anything too surprising, but are the complaints in the dermatomal distribution? Is there a mass or a bump or swelling? Is there a neurologic deficit, either paresthesias or weakness? Is there pain? And what was the time of onset? Like I said, a lot of the benign tumors grow slowly, whereas the malignant tumors are much more rapidly growing. And on physical exam, are there sensory deficits, motor deficits, and do you feel a mass? So this is the EMG neuromuscular block. So electrodiagnostic evaluation, EMG and nerve conduction abnormalities in the setting of the peripheral nerve depend on a lot of these same things: location, proximity to other nerves, degree of myelin loss, if any, degree of axon loss, if any. Benign tumors typically do not infiltrate axons. If there is axon loss, it'll likely be minimal degree, and you're more likely to see loss of snaps, but no EMG finding. In contrast, malignant tumors are more likely to have axon loss. This is for twos in the EMG lab. This is what we do. This is a picture of Shrid looking at a picture of Shrid looking at a picture of Shrid till about like 10:30 or 11 at night. There's been numerous reports of various peripheral nerve tumors in the literature, but presentation in EMG labs is rare, and subsequently there's infrequent reporting in the EMG literature. EMG studies can reveal prolonged sensory latency and diminished or absent sensory evoked potentials. In some case reports, Aiden et al. Had a patient present with sudden onset sensory change in the radial 3 digits, of her right hand. So what do you think the radial 3 digits of her right hand? Anyone? Yeah, so carpal tunnel, but this shouldn't be a sudden onset. Radiographs were negative. EMG diagnosed medium nerve entrapment, but this is all of a sudden medium nerve entrapment. Surgical exploration revealed a hemorrhagic mass, and later the pathology showed a ruptured schwannoma. Feinberg and Sethi report a case of a 52-year-old male who had this long history of back pain and had 2 months of pain, cramps, and weakness in the left lower limb, which may be a pretty common complaint in the EMG lab. Nerve conduction findings of sensory and motor abnormalities. A needle exam with EMG changes, but normal motor units. In short, it was suggestive of a left sciatic neuropathy due to a tumor in the end. Because one other thing on exam is a sensory distribution start all of a sudden? Is there a particular place that we see a sensory change that's not a spot of entrapment? Like it's not at the cubital tunnel, it's not Guillaume's canal. The middle of the thigh is not a common site of entrapment. Pardo, Fernandez, and their group, they performed a case control study to evaluate the use of electrodiagnostic testing to evaluate for Morton's neuroma. They use subdermal electrodes, which are down here in the corner, and we don't usually use. These are often used for intraoperative monitoring. And they stimulated orthodromically. And they showed a higher sensitivity and specificity compared to MRI. And MRI is sort of the gold standard. So this was an interesting finding that they were picking up tumors that MRI didn't. So that also showed a lack of correlation between the size of tumor and symptoms. I don't have my, okay. So radiology, we'll talk about X-ray, ultrasound, CT, and MRI. X-ray is really non-specific and usually non-diagnostic because of the poor soft tissue detail. So low utility. We'll discuss one major exception later. Nonetheless, often just because of insurance, you do have to start with these, but it's uncommon that you're going to see much. And CT similarly. Ultrasound, however, is a useful primary evaluation for peripheral nerve tumor. And this is a place that if you're utilizing ultrasound in your clinic, might be able to take advantage of. And Bignati and his group performed a meta-analysis of ultrasound versus MRI for the diagnosis of Morton's neuroma. And they found ultrasound to be equally sensitive to MRI in detecting Morton's neuroma with a pretty high confidence interval. MRI still provides the best imaging of peripheral nerve tumors. Most benign nerve sheath tumors on T1 are iso-intense or somewhat hyperintense relative to muscle. On T2 are hyperintense to fat with high intensity peripherally and with a center with low to intermediate intensity, thus giving a target sign. And I'll show some more of that later. Fusiform shape, described as longitudinal in orientation with tapered ends that are connected to the parent nerve. And Murphy said that the fusiform shape is the singular most identifying feature on MRI, is this fusiform shape. That's what we saw on our gentleman. On the left, you see this is the fascicular sign. It's a description of the multiple ring-like intensities and Dr. Sridhara's preferred bag of marbles thought to reflect the fascicular bundles. And this is the split fat pad sign, which occurs when the tumor is within the nerve and surrounded by fat. So you see these arrowheads are pointing out that rim of fat. So treatment, this depends on the pathology, the locale, severity of the symptoms. Watchful waiting is indicated if the symptoms are bearable, if the excision is going to be difficult, and as is true for most of the tumors, low possibility for METs or for further local mass effect. Surgery is the primary treatment for many and often requires microvascular dissection. And radiation, in some cases, is an adjuvant for pain management. And so one of the big questions for these lesions for surgery is how much is it going to affect the nerve? If you're doing a dissection, are you going to be left with neurologic deficits in that nerve distribution, which in some cases could be a lot worse than the symptoms themselves? Gosk and his group regarding this had 94 patients, from which 101 tumors were removed over 19 years. And the symptoms prior to surgery, this is in decreasing order of frequency, were mass, positive Hoffman-Tunnell sign, paresthesia, sensory deficit, pain and motor deficits. 94 of them were benign. And post-operatively, patients had pain relief almost 88% of the time, negative Hoffman-Tunnells 84%, almost an 80% resolution of paresthesias, improvement in sensation a little over half the time, and motor improvement in 26%. So you've got to look at, again, what are the symptoms, how bad are they, and where is the tumor? So now we're going to talk about various tumors, specifically the divisions of benign peripheral nerve sheath tumors, other nerve tumors, malignant peripheral nerve sheath tumors, and what I'm going to talk about is imitators. There is some ambiguity about how to define various lesions. I did it based on things that were benign from the sheath, still of neural origin, malignant, and then things we find in the nerve but are less of local origin. So benign peripheral nerve sheath tumors far outnumber malignant ones. Benign tumors cause symptoms, once again, due to compression and not due to axon loss. And if there is axon loss, it's usually minimal. And these include a big group, neurofibromas, schwannomas, perineuromas. I'm not going to read the whole list, but we're just going to talk about schwannomas and neurofibromas because they are the two most common. Schwannomas are also known as neuronoma, perineural neurofibroblastom. So if you see any of these, and I saw them all used interchangeably in the literature, they're still talking about schwannomas. And they arise from the Schwann cells, which form the myelin covering of the nerve. And these are encapsulated by the perineurium. They typically are benign and slow growing, rarely malignant, but in rare cases, there are malignant schwannomas. They most commonly occur in the flexor surfaces of the extremities, especially the ulnar and perineal nerves. And clinically, they can present with paresthesias and pain if they're symptomatic. This will, for the early 90s. Epidemiology, they can occur at any age, but typically ages 20 to 30. Males and females are equal, and they account for 5% of soft tissue neoplasms. There's also a rare association with NF1. On radiology, there's that fusiform shape that I talked about earlier, with a well-defined mass, typically less than 5 centimeters in diameter. And they often look like neurofibromas and can't be distinguished on MRI. So this is one place that's challenging when MRI is used as a question of excision. Whether or not they're encapsulated might affect that excision. Typically a surgical treatment, and they're often easily separable from the nerve, and there's good preservation of nerve function, and they rarely recur. So here we see the nerve appears central with the capsular, which is inside, and the image reveals the surroundings split fat pad sign. I think that was a different image. Sorry. Neurofibromas. These present as distinct subtypes, and I'm not going to cover all three. We're going to talk about the localized neurofibroma, which is more common, accounts for 90% of the cases, and this does not have the neurofibromatosis type 1 association. The diffuse type, which is associated with NF1, is seen in children and young adults, and the plexiform, which is associated with NF1, is more likely to be malignant and can also cause elephantitis. So what the next couple slides are about the localized neurofibroma. They're typically more superficial as they originate from small nerves. These are fusiform lesions. They centrally enter and exit the nerve. They're typically benign and slow growing, rarely malignant, but once again, they can become malignant. So unlike schwannomas, they may remain within the epineurium and thus have a capsule-like covering, but they are not truly encapsulated. So it may appear that way, but that's one of the distinctions. This is a picture of a gross specimen from after surgery. You see the capsule is the white arrows, or the pseudocapsule. And there's the peripheral myxoid region, which is the black arrow here, and the centrally more solid tissue. About 5% of benign soft tissue tumors, once again, younger patients, and the isolated variety is not affiliated with NF1. In radiology, MRI, the fusiform, well-defined mass, typically less than 5 centimeters in diameter, more centralized than schwannomas. The utility of surgery, there seemed to be some conflict. Some authors said that there was a close association with the nerve of origin, and thus it made it difficult to separate the nerve surgically. But others report, similar to schwannomas, that there's easy separation and good preservation of the nerve. If removed, there is rare recurrence. So this is so on the left, there's the sagittal image that shows the entering nerve and partial fat. So there's the split fat pad sign, and on the capsule. And on the right, the axial shows a high intensity peripheral rim. So this is your target sign. So you have sort of the bullseye look. Other benign nerve tumors. So these may not be true tumors, but they are of neural origin. We're going to talk about neurofibrolipomas, Morton's neuroma, and traumatic neuroma. Neurofibrolipomas, also known as fibrolipomatous hematoma of the nerve, peripheral perineural lipoma, fatty infiltration, and so on. There's an association with macrodactyly here. In that case, it's known as macrodystrophia lipomatosa. Clinically, patients will have swelling, plus or minus pain, plus or minus neurologic symptoms. Epidemiology is a little different here. These are often present at birth. In early childhood, may even be congenital. After age 30 or 40, they're rare. Male equal female, no familial predisposition. Treatment is difficult, controversial, and varies with extent of tumor. So this is a picture. This is a hand. So see the thumb coming out on the left. And this is the example of where X-ray may actually be more useful. This is a patient with macrodactyly, and this is ultrasound. So this is another one where ultrasound can be a useful diagnostic tool. You see the alternating stripes. There is what you're looking for. But MRI is the best modality. And you'll see longitudinal cylindrical foci of low signal surrounded by fat, and that's pathognomonic for the neurofibromas. Morton's neuromas are non-neoplastic. They're perineural fibrosis, so they're thickening of the plantar digital nerve at the bifurcation due to thickening of the perineural fascicles, perineural fibrosis, and loss of myelinated fibers. There's two theorized etiologies about how these lesions arise. One is secondary to compression against the intermetatarsal ligament, but it seems to be lacking biochemical evidence. Second is secondary to ischemia. So this is a resected specimen, and you see this is the plantar digital nerve at the bottom entering, and this is the mass. Epidemiology, females greater than males 18-1, so high-heeled shoes are a potential agitator catalyst. Presentation, patients will have exercise-induced pain that's relieved by rest. It radiates proximally and distally. Up to 30% of the lesions present asymptomatically. Conservative, unfortunately for the ladies, and I guess for the gentlemen's, footwear modification is the first step. If conservative management does not work, there's other treatment modalities, including neurolysis, steroid injection, which I know at least Weineck does occasionally, and ultrasound therapy. But once again, surgical resection of the neuroma and the involved segment is a definitive treatment. Just have to take that off the screen. It was up there too long. MRI is still the best modality. You see lesions are centered in the neurovascular bundle on the plantar side of the transverse metatarsal ligament within the intermetatarsal space. You can sort of see that here at the star. This is a 6 millimeter mass in the interspace between the third and the fourth. But you do have some help with ultrasound, and this shows the marked enhancement and vascularity of the lesion. This is another place that are using ultrasound, becoming familiar as a way to improve diagnosis and in the clinic. Traumatic neuromas, I'm going to speak more briefly on because we've had talks on this, and it's a larger topic, and they're growths that result from the proliferation of an injured or either partially or completely transected nerve following trauma or surgery. Amputation is one of the places that we're most familiar with this. And it's the multidirectional cell proliferation as the nerve attempts to repair itself. These are non-encapsulated, disorganized mass of axons, endoneurial cells, perineural cells, Schwann cells, collagen, and fibroblasts. So this nerve is trying to, after insult, return to how it was, and it's like a car without a map or a road, and just becomes this big tangled mass. And the pain is often reducible with palpation or tapping. It's the most commonly following amputation, most frequent in the lower limbs. As I think we've had talks specifically on this and the pain and management of it, so I'm not going to get into that much. Malignant peripheral nerve sheath tumors, a wide array of pathologies. You get the neurogenic sarcoma, malignant schwannoma, neuroiberosarcoma, epithelioid, glandular, and rhabdomyosarcomatous. And this is a photograph of a gross specimen that shows multinodule thickening of a plexiform neurofibroma of both sciatic nerve and its branches. So the solid arrows are the branches of the nerve, and a necrotic center. These are less frequently encountered. They grow rapidly, more likely to cause pain and neurologic deficits. As a rapid enlargement of a nerve mass has 95% positive predictive value for predicting malignant pathology. The presence of neurologic deficit has a positive predictive value of 73% for malignancy, and weakness per SEGRU is exclusively found in malignant tumors. These are able to be distinguished preoperatively based on clinical and radiographic findings. Now some imitators. So these are other masses that are found in the peripheral nerves that can present with mononeuropathy and mass, but are of sort of different origins. There's intraneural ganglion cysts, metastases, primary lymphoma, sarcoidosis, and neuritis ossificans. And there's others that have been documented but are less common, and given the scope, these are sort of limiting to the ones that we might encounter. Intraneural ganglion cysts, these are mucinous cysts that are of synovial or articular origin. There's different theories regarding the pathophysiology. There's formulation of the fluid along the path of least resistance in a joint. So that one author described it as a capsular rent into the articular branch, or propagation of fluid from a degenerative joint. These are most commonly found in the peroneal nerve and close to the fibular neck. The treatment is surgical intervention and requires drainage of the cyst without interrupting the nerve. And you also have to do a partial resection of the synovium to prevent recurrence. So it's not just a slice and dice and drain the cyst in this case. This is a picture of a gross specimen. You see they described as a gelatinous and myxoid consistency, septations, and the fibrous wall of the ganglion. So this I thought was a good picture sort of describing how this occurs. You have the normal at the top and the fluid rising proximally up the common peroneal nerve. On radiology, they cause a signet ring due to the eccentric contraction of the nerve within the cyst. They may have a radiographic appearance similar to some of the true tumors. Skinner and his group reported a case where one MRI was initially read as a nerve sheath tumor, and only upon further review was reclassified. And this is significant because, once again, the treatment for a schwannoma is going to be a lot different than for the cysts. So you don't have to do that excision around the nerve as much, but you do have to treat the synovial source. This is a fat-suppressed T2 image showing a fluid-appearing mass. You see these arrowheads adjacent to a proximal fibula and peroneal nerve. So metastasis, true isolated mets to peripheral nerves are rare. And I'm separating somewhat the plexus versus the peripheral nerves. Mets to more proximal compartments in the axilla or the brachial plexus, the groin, the lumbosacral plexus, and the supraclavicular area are more common. Because of their proximal locations, they may be close proximity to the primary lesion. And these are also unencapsulated compared to the peripheral nerve. Meller and his group discussed why peripheral nerves are less common sites for METs, but did propose ways in which the direct structural anatomic mechanisms by which tumor tissue can alter the function and integrity of the peripheral nerve. And here you see that the tumor mass can stretch the nerve by pushing on it without direct invasion. It can compress or strangulate the nerve by engulfing it without genuine invasion, or it can perforate the nerve sheath directly and invade between the fascicles. So that's in the cases we do see these. Primary lymphoma of the peripheral nerves is very rare, whereas lymphoma can be seen throughout the body. The peripheral nerves is less common. There have been reports on the sciatic nerve, radial nerve, sympathetic chain. These are usually B-cell origin, variable prognosis, and of note they can cause a Guillain-Barré-like syndrome when they do occur. Sarcoidosis. The frequency of sarcoid manifesting neurologically is approximately 1 to 27%. The average was said to be 5. Of that, most is accounted for by cranial nerve manifestations. It can affect the peripheral nerves either as a mononeuropathy multiplex or in isolation. and if peripheral nerves are involved, typically later in the course. Chandler evaluated the frequency, not the frequency, which would be the frequency of peripheral nerve involvement in asymptomatic sarcoidosis patients. So there's 29 patients with known sarcoid and 29 age-matched controls. 19 of the sarcoid patients had abnormality on electrodiagnostic testing, including low sensory amplitudes in one or more nerves, lower mean sensory amplitudes for median, ulnar, and sural nerves. And other studies have shown conduction velocities and denervation abnormalities. Neuritis ossificans. So this is similar to the reactive, this is a heterotopic ossification of a peripheral nerve, similar to what we talk about with HO in our patients. It's a rare pathology. The etiology is unclear, but likely secondary following injury, as it's associated with trauma surgery and other nerve insults. It presents as a mononeuropathy with pain, variable weakness, and palpable mass along the nerve distribution. The workup, x-rays, this is one area that x-ray is more useful than for other entities. They show a well-circumscribed radiopaque lesion, which is suggestive of a calcification. And if you see this, an MRI or a CT should be sought, because if calcification is seen, biopsy is needed to rule out soft tissue sarcoma, which is one of the other concerns. Treatment is microsurgical dissection. Neurologic deficits are common after treatment of this. And radiation may be used as pain treatment, but does not affect the neurologic deficits. Prognosis is good if the nerve remains intact postoperatively, and recurrence is uncommon. So some take-home points. Be aware that these exist. These aren't going to be your common radiculopathies. These aren't going to be your common diabetes, peripheral nerve pathologies. Be more suspicious if you have younger patients with an insidious onset. If you have patients who don't have risk factors like no trauma, they're not doing repetitive activities, like typing or driving with their knee against the door. If there's difficult to localize lesion with electrodiagnostic studies, if you've got compression at an atypical site. So if you're concerned, get a MSK ultrasound and or MRI. These are usually benign, and the benign do not typically cause pain. Should be more concerned for malignant if pain is at rest, if there's neurologic deficits, or there's a more rapid onset of symptoms. And if it's malignant or certain types of intraneural tumors, surgery may be complicated with potentially poor prognosis. So you need to find a surgeon who does this specific microsurgery on the nerves. So that's about it. I want to thank Dr. Shred Hara. He's gone to the Hair Club for Men. And Dr. Santiago for breakfast. And Dr. Yu on the EMG survival tactics. I don't have family, but on our rock climbing to prove that I'm not just talking about it all the time. That's up in New Hampshire. You're right. So that's it.